Hi everyone, my name is Louise Garces, and together with my other group members, Hannah and Cheyenne, we will present our gait analysis assignment. The assigned gait deviation for our team is the trunk lean, so Hannah will start off by talking about the first video.
So for the temporal spatial measures, we used the estimate and said that the tile was an 8 by 8 foot tile. So the take home from this slide is that the step length, cadence, and the gait speed, um, all three of those values were lower than normal. And based on the gait speed of this subject, the patient may have difficulty or limited ability to walk in the community and is at an increased risk for falls. So the primary gait deviations that we saw in this video was that the subject had a lateral trunk lean to the left throughout the stance phase, and he also had limited knee flexion seen throughout the entire gait cycle, and this is seen, so again, through the entire gait cycle, so throughout stance and swing phase. So for the lateral trunk lean, we hypothesized that this could be due to either weak hip abductors or pain. So the left hip abductors may cause a compensated response of a left lateral trunk lean during single limb support. Because if the hip abductors are weak, this may cause the person to lean to the left, and this in turn will cause a shortening of the moment arm and therefore decreasing the amount of external torque that the hip abductors have to counteract. So for pain, again, this could also be due to pain by leaning the trunk over to the left. This decreases the amount of compressive forces acting at the hip, and this could be seen for people with osteoarthritis or RA. Another primary gait deviation that we saw was knee hyperextension throughout stance phase and swing phase. So for stance phase, this could be due to weak quadriceps because during this time, the quadriceps are absorbing the load, and in turn, we'll usually see knee flexion. But for him, he has hyperextension at the knee, and this is a compensation that's seen for weak quadriceps so that the quadriceps wouldn't have to work as much by locking the knee out. And for limited knee flexion during swing phase, this could be due to weak hip flexors because the knee flexion that we usually see during this phase is usually due to the hip flexing. So for gait efficiency, we talked about lateral displacement of the body. He had too much of a wide walking base, and this increases the amount of work that the hip abductors have to do, even though it also does provide the patient with more support for balance. And for knee flexion during stance phase, he has limited to or close to no knee flexion during stance phase of the left limb, and this increases the length of the lower extremity, and it's more work for adequate clearance of the contralateral limb that's swinging through. And this increases the height of the center of mass. So in terms of the function, we said that this would affect single limb stance because the hip abductors play an important role during this time of the gait cycle where it keeps the pelvis level, and we'll see like shifting of the trunk and the body's center of mass laterally over the stance limb, reducing the amount of force needed to be produced by the hip abductors of that stance limb. And the lateral trunk lean also helps to reduce the compressive forces on the stance hip as well, like I said before. So for the PT's role, an article in the Journal of Orthopedic and Sports Physical Therapy supports the fact that a lateral trunk lean would give a patient with problems at the hip and hip musculature, in that it decreases the amount of activation of the hip abductors on the ipsilateral side. Therefore, therapeutic exercises to help strengthen the hip abductors of both limbs would help decrease the need for the patient to lean towards the left. Exercises to also strengthen the knee extensors would also address the lack of knee flexion during stance phase and loading response. In that it could help the patient develop eccentric control of the knee extensors and help the patient feel less afraid to flex the knee with a load. And also strengthening the hip flexors would address the limited knee flexion during swing phase of the gait cycle. And implementation and education on using an assistive device to help in decreasing the amount of muscle force needed to keep the pelvis level will help decrease the gait deviation. And we would instruct this patient to keep the assistive device or the cane on the contralateral side of the weak hip. So this would be his right side, and we would help educate him on that. So I'm going to show this video, and Cheyenne will talk a little bit more about this video.
So these are the temporal and spatial measures estimated under the assumption that the walkway was about 5 meters. The indication from this table is that the step length, cadence, and gait speed all fell below the typical values for his age group, displaying the inefficiency and decreased functional ability of his gait. The first deviation we'll discuss is the posterior trunk lean, which is present throughout the left gait cycle. However, it's especially exaggerated during loading response from initial contact through to opposite toe off. Note that the shoulders are posterior with respect to the hips, denoting the posterior trunk lean. The next deviation is foot flat initial contact, which is present during the stance phase, specifically loading response, and it's especially noticeable at initial contact as the entire foot contacts the ground at once. The last deviation we notice is knee hyperextension, also present during stance phase from mid-stance through to terminal stance, as inadequate dorsiflexion in the reference limb is exhibited as the opposite limb is progressing through swing phase. The posterior trunk lean during loading response moves the line of gravity of the trunk behind the hip to alter the ground reaction force to behind the hip. This reduces the need for an internal hip extensor torque and compensates for gluteus maximus or hip extensor weakness. The foot flat initial contact is due to marked weakness of the ankle dorsiflexors, without sufficient strength to control eccentric dorsiflexion during loading response. Inadequate dorsiflexion during swing to allow the heel to contact the ground first is also present, causing foot flat. The knee hyperextension through stance serves as a potential compensation for lack of ankle range of motion into dorsiflexion as the body progresses over the stance limb. This may be due to plantar flexion spasticity. A potential hypothesis for the patient's pathological condition is Duchenne's muscular dystrophy, as the patient presents with some of the hallmark postural and gait deviations associated with Duchenne's, similar to the picture on the right. In terms of gait efficiency, stance phase knee flexion was affected. The lack of stance phase knee flexion in this individual impacts his ability to reduce the upward displacement of the center of gravity, causing for more vertical displacement. Ankle mechanism was also affected. Due to the foot flat initial contact, the individual is unable to reduce the downward displacement of the center of mass, further causing for more vertical displacement. In terms of function, weight acceptance is most affected due to the presence of a foot flat initial contact as well as a posterior trunk lean during loading response. The individual's lack of dorsiflexor strength, hip extensor strength, and ankle mobility is affecting his ability to accept weight during loading response, leading to several gait abnormalities. In terms of interventions, hip extensor or glute strengthening therapeutic exercise administered at a submax aerobic and low resistance strength training level with the aim of strengthening neuromuscular rehab as well as improving the ability of the weak proximal hip muscles to stabilize the hip during loading response would be indicated. A hinged AFO with functional E-stim to the ankle dorsiflexors, using the AFO for dorsiflexion assistance plantar or to stop plantar flexion to improve stability of the ankle joint during gait, combined with functional E-stim to prevent atrophy and activate and provide neuromuscular rehab to the ankle dorsiflexors would also be indicated. Now that we've analyzed each video individually, Luis will discuss similarities and differences.
So there were two major similarities depicted in the video. First, knee hyperextension was present for both subjects during the stance phase. This is captured by the pictures on the lower left side of the screen. Second, trunk lean was present during stance phase as a compensation for possible muscle weakness. This is captured by the pictures on the lower right side of the screen. In terms of differences, the first subject was a male estimated to be in his 70s, whereas the second subject was a male around 10 years of age. Video 1 showed a lateral lean, whereas video 2 depicted a posterior lean. The subject in video 1 demonstrated a heel contact for both feet, but the subject for video 2 had a flat foot initial contact. Due to these notable differences, hypothesis for the underlying muscle weakness was different. For video 1, a lateral lean may imply weak hip abductors due to the inability to keep the pelvis level during single limb stance. For video 2, a posterior trunk lean may imply weak hip extensors because a posterior lean moves the line of gravity of the trunk behind the hip, reducing the demand on hip extensors. Meanwhile, pretibial muscle weakness may explain the flat foot initial contact because the pretibial muscles eccentrically control the external plantar flexion moment that occurs during loading response. Another thing to note between the two videos is that for video 1, no arm swing was present on the left side, whereas for video 2, there was a synchronous arm swing. So these are the reference that we use for our presentation. Thank you for listening.